Okay, our next section, section 5, is going to be drilling a little further into the issue of non-adherence and how clinicians might handle different components of that. We'll talk about adverse drug reactions, measuring perceived side effects. I'm going to talk about FIBSR, a tool that I like, and communication about side effects. So here in our next slide, we have adherence algorithm. And this is how a clinician might think about adherence assessment. So as I've mentioned before, assessing adherence is hard and needs to be done repeatedly. One way to think about is a patient that appears to have adequate adherence, in your opinion. In that case, you would just continue to routinely monitor adherence. Or if a person appears to have inadequate adherence, then you might further go into that to try to figure out their reasons for presumed suboptimal adherence. So one major way that I think about it is the person can't versus they won't take medication. So cannot, that those categories could be cognitive deficit, substance use or abuse, medication-related factors. They may have tolerability issues. They just might have adverse events or intolerance to medication. Their life may be very chaotic. They may have a lack of routines. There could be logistic problems. Maybe they can't afford their medications. They could have persistent symptoms that might make it tough for them to take medications. Maybe they're paranoid about the drug, for instance. Or they will not take the medication. That could include lack of insight, stigma concerns. Persistent side effects could go into this, a poor therapeutic relationship, lack of family or social supports, and again, persistent symptoms also. So ideally, you want to tailor the interventions to address the specific causes of suboptimal adherence based on those variety of factors. And I do want to say that even though we have this nice little algorithm here, often we can have people that might have some reasons for poor adherence that are in the cannot profile as well as in the will not profile. So that makes things a little bit more challenging for the clinician. So the next thing that I want to talk about in this section is adverse drug reactions as a function of increasing age. So side effects often are not significant in younger people. Right around the age of 50, adverse drug reactions, or ADRs, per 10,000 of the population really skyrocket. For those of us, yours truly included, who are above that category, we definitely notice that there are aging-related changes, and increased likelihood of ADR is one of those. So thinking back to our case reports, in Marie, as she got older, she started to have more problems with taking lithium. The other thing I want to talk about is measuring perceived side effects. So particularly for people that might be in that older age window where they're more likely, but also across the full lifespan. The STAR-D study for unipolar depression used a scale called the Frequency, Intensity, and Burden of Side Effects Rating Scale, or FIBSR. It can assess and consider tolerability of side effects to weigh the cost and benefit of a dose change. We know that side effects can impact quality of life and treatment adherence in mood disorders, as any disorder. And FIBSR really can be used, if you tweak the words a little bit, for any kind of psychotropic medication or psychiatric disorder. So here's an example. Number 1, choose the response that best describes the frequency. So how often of the side effects of the medication you have taken with the past week for your depression. You could substitute a different psychiatric illness. And so the person says whether they have no side effects or the other extreme present all the time. And then question 2 describes the intensity of the side effects. So how severe? Is it trivial, moderate, marked, severe, intolerable? Third question is choose the response that best describes the degree to which the side effects have occurred and impair you over the last week. So how much interference has this side effect impacted your functioning? So from no impairment all the way to the extreme of unable to function due to side effects. So that could be a tool and a point of discussion. It can help you decide with your patient whether a particular side effect is tolerable or not. Is it going to be a key driver in poor adherence? And it really can take the focus away from being judgmental or whether somebody's a bad doctor or a bad patient. It really is designed to jumpstart that discussion and can be very helpful in treatment decision making. The other thing that could be a tool is helping individuals to communicate with providers about side effects. So we do this in some of our adherence promotion programs. We ask people to be clear on a generic and a chemical name. So we have definitely seen patients who do not appreciate, especially if they've got drugs from different pharmacies, that the same drug can have different names. So it is important that people understand that, what the medication is typically intended to treat, as well as the purpose of the medication in their situation. So is it an antidepressant? Is it a general mood stabilizer? And so on. Their personal response to the medication, asking the patient to quantify the side effect or problem. So this is a little similar to the FIBSR. Is it a mild, moderate, or severe side effect? Suggestions from their treatment provider about how to manage this side effects. Is this something that just needs to be tolerated because there's no other choices? Or, is there something that the person can do? Maybe they could take it at a different time or other alternatives. And then side effects that the person has not personally experienced, but which they are concerned about or fear may happen in the future. So, for example, some patients with bipolar disorder are afraid of taking lithium because they've heard very bad stories about it and are fearful that those things could happen to them. So basically, good effects, bad effects, and what have you experienced? There's no one approach to managing side effects. It really depends on the patient and their circumstance. The number one thing is that patients and clinicians need to communicate about options and potential solutions. So the key points here is, while there are many reasons for poor adherence, and these vary on individual patient circumstances, experienced medications or side effects that patients are concerned about can drive adherence behaviors. Patients can vote with their feet. They can stop taking medications due to side effects. And there are tools like the FIBSR that clinicians can use to help understand the burden and impact of side effects. And then finally, shared decision-making between patients and clinicians may help identify how best to balance benefit versus burden of a given medication regimen.